Hey everybody, and welcome back to another video here at Whiteboard Doctor. We appreciate you checking it out. Interesting topic today, and that is the four shock states: distributive, hypovolemic, obstructive, and cardiogenic. We're going to dive into these four shock states, into understanding them, the pathophysiology, the management, the different causes within each category. But to do that, we're actually going to use a framework that we introduced in the first video in this series. We're going to link it in the video description. It's going to be a framework for understanding undifferentiated shock, and it uses the oxygen delivery and oxygen consumption equation as broken down into really finite parts to understand the diagnosis and management of these four shock states. So definitely check that out if you have not. It's linked in the video description. If you feel comfortable with that, or you want to just go on right ahead, let's rock and roll. So with no further ado, quick 60-second break for introduction. We'll see you right back. Hello everyone, and welcome to another video here at Whiteboard Doctor. Thanks for joining us today. Here at Whiteboard Doctor, our mission is to provide you with free, interesting, relevant, understandable medical education and news for all types of lifelong learners, trainees, and practitioners. We have weekly videos that we debut Fridays at 5 p.m. Eastern Time with bonus medical education videos posted throughout the week. We'd love for you to join the Whiteboard Doctor community and follow along by hitting the subscribe button located in the bottom right-hand corner. We also encourage all likes and comments, even if it is just to say hello. All our video descriptions contain links for additional related videos that might be interesting, so don't forget to check those out. And lastly, a quick disclaimer: none of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on. With no further ado, stay well, keep learning, and let's get to the video. All right, thanks for sticking around. So the four shock states, this might be familiar to some of you, maybe not familiar to others, but shock, as we talked about in that first video, we defined as tissue hypoxia. And when tissue hypoxia occurs, it can be from a lot of different things. Maybe the heart isn't squeezing hard enough to pump blood forward. Maybe you're bleeding and don't have enough hemoglobin. Maybe you're in septic shock and your tissues are utilizing an incredible amount of oxygen. We divide these into four general categories of shock to help us better understand what exactly is going on. Within each one of these categories, though, there's multiple different causes. So the first category, and often the most common category, one study from a level 1 center found that of all patients presenting in shock, 64% of them were in something called distributive shock. We will further understand distributive shock and define it in a bit, but distributive shock is also broken down into multiple different subcategories. Things like septic, endocrinopathies. Again, we'll talk about this more in a bit. The second most common cause of shock is hypovolemic shock. You could be very dehydrated, you could be bleeding, etc., etc. After that is cardiogenic shock, a pump problem, the heart isn't squeezing hard enough. And the least common cause is obstructive shock. Maybe you have a massive blood clot. You have fluid around the heart causing tamponade. Again, all things we'll talk about. So we categorize shock into these four general categories. But know that these aren't perfect silos. So even within the four categories, so within distributive shock, we're going to talk about a bunch of different things that can cause quote-unquote distributive shock. But all of them behave a little bit different. So we use these four general categories to help us understand shock, but it's not perfect. Things are not totally uniform within each specific category. So to start, distributive shock. What is going on? What is distributive shock? Well, what happens in distributive shock is you often get a degree of systemic inflammation. Sometimes this is from septic shock, or you have an infection that is causing systemic inflammation. This could also be from things like pancreatitis, right, where you get a large degree of inflammation throughout the body because your pancreas is inflamed. You also sometimes see distributive shock with things like endocrinopathies. So maybe your adrenal crisis. Endocrine, I put a P too soon. This is why I shouldn't try to spell things in real time. Not that anyone could read my writing anyways. Endocrinopathies. You can also see this with anaphylaxis, or a severe allergy, where your body starts to have a large degree of systemic inflammation. What happens here is you get vasodilation, or your blood vessels start to dilate, and then those blood vessels get leaky, or the capillaries start to leak more tissues into the interstitium. So the capillaries, many of you know, but you have arteries that go into arterioles, that go into venules and veins, right? And this is kind of what the system looks like all throughout the body, right? Blood flows with oxygen through the arteries. The capillary here, cap, has kind of the gas exchange, right? Oxygen goes into the tissue, CO2 goes into the capillaries, and then blood flows through the veins up to the heart, right? So artery, vein, capillary. Well, these capillaries start to get more leaky, right? They start to have kind of more gaps in them. So then fluid can flow into the tissue to get increased capillary permeability. If we look down here, this equation, this is from the first video. It's the oxygen delivery versus oxygen consumption equation. Because we said shock is that you can't deliver enough oxygen for the amount being consumed. And the reason in this case you're having trouble delivering enough oxygen is because there's a much higher degree of oxygen consumption in distributive shock, right? You have this systemic inflammation. All your tissues are in overdrive. They're consuming a bunch of oxygen. All right. In addition to that, we said you get vasodilation. Vasodilation is going to decrease your preload and decrease your afterload. All right. So this is the pathophysiology going on. With a decreased preload and a decreased afterload, you're not able to deliver as much blood volume, right? If you guys watch that first video, you know that these three things are proportional to the stroke volume, right? And heart rate times stroke volume equals cardiac output, or the amount of blood the heart is pumping around. So the problem here is in distributive shock, you get vasodilation. Your preload's low, your afterload is low, so you can't deliver as much oxygen because your cardiac output could drop. You have increased oxygen consumption in the peripheral tissues. So what does your body do to compensate? Well, compensatory, you get an increase in your heart rate and an increase in your contractility. These two compensatory mechanisms actually lead to an increase in your cardiac output to try to keep up with oxygen delivery, this side of the equation, to keep pace with the amount of oxygen consumption. But at some point, if you get sicker and sicker, this compensatory mechanism, this increase in cardiac output by increasing heart rate and increasing contractility, cannot keep up with oxygen consumption. And that then leads to the tissue hypoxia, right? So the pathophysiology of distributive shock is vasodilation and increased capillary permeability, increased oxygen consumption in the peripheral tissues, decreased preload, decreased afterload. These are all pathologic changes. The compensatory change is an increase in heart rate, increase in contractility. And at some point, if you get sicker and sicker, that compensatory mechanism can't keep up and your oxygen consumption outpaces your oxygen delivery and you go into distributive shock. So how do we treat this then? Well, let's look at the pathophysiology going on. Oxygen consumption, really hard to modulate this, right? There's things you could try to do outside the area of this video, but in oxygen delivery, what things can you modulate? Well, your body already cranked up the heart rate and cranked up the contractility on its own. But we talked about how there's a decrease in the preload and the decrease in the afterload, and that those two things are decreasing the stroke volume. So what we can do is we can give fluids and vasopressors, right? Fluids and vasopressors like norepinephrine or Levophed to increase the preload, so knock that out, and then vasopressors to increase the afterload, knock that out, and as such modulate and increase the cardiac output even more to try to keep pace. So that's the treatment among addressing the underlying problem to distributive shock, fluids and vasopressors to try to reverse the pathophysiology going on here. So see how this equation, the oxygen delivery and oxygen consumption equation, can guide the diagnosis and management. If you understand the pathophysiology, you can understand how to diagnose it and then how to intervene on it, right? The pathophysiologic change, the compensatory change, and then what we can do to help the body better compensate. All right, so that is distributive shock, the most common cause of shock. Within distributive shock, septic shock is usually the most common, right? An infection that causes, diffuse inflammation throughout the body. But pancreatitis, pneumonitis, other itises can cause systemic inflammation, endocrinopathies, anaphylaxis. Neurogenic shock is often batched in distributive shock, although it does behave a little bit different. Because in neurogenic shock, you don't get the compensatory increase in the heart rate, you remain bradycardic. Because neurogenic shock is going to be injury to the sympathetic chain, so you can't mount that compensatory tachycardia. but it's still usually batched in distributive shock as well. So that is shock state number 1, distributive shock. Shock state number 2, hypovolemic shock. So same exact pattern here. Hypovolemic shock can be from severe dehydration, right? You just don't have enough fluid in the body. It can be from hemorrhage or bleeding or losing too much hemoglobin. It can be from this entity called third spacing, which we don't talk about as much, but it's where too much fluid leaks into kind of other areas of the body. But the two big ones are dehydration, hemorrhage, or, even volume loss. So you have severe diarrhea. Things like cholera can cause severe volume loss. And the progression here is you get severe volume loss, as we talked about. That leads to a decrease in preload. So same pattern. With red, you get a decrease in your preload. All right. If it's hemorrhage, if it's bleeding, you also get a decrease in your hemoglobin, right? So now we're having a decrease in both the cardiac output part of this equation, as well as the arterial oxygen content part of this equation. To compensate, your body increases the heart rate, it gets tachycardic, and it vasoconstricts, it increases your afterload, right? So what that does then is that tries to maintain the cardiac output to keep up with oxygen consumption. At some point, though, if this gets so bad that even increasing the heart rate, increasing the afterload, cannot keep up with oxygen delivery, that is when you start to get shock. You start to get tissue hypoxia. So what can we then do to help optimize the oxygen delivery portion of this equation? Well, if they're bleeding and their hemoglobin's dropped, you can give them blood transfusions, right? You can increase their hemoglobin. If they're in hypovolemic shock, they're dehydrated, their preload is low, you can, we should stay consistent. Transfuse PRBCs, packed red blood cells. All right. If it's hypovolemic shock from dehydration or volume loss, and their preload is low, you can give them fluids. So again, see here this equation we can use to diagnose as well as identify what to intervene on. So hypovolemic shock, hemorrhage, dehydration, volume loss. In the United States, hypovolemic shock is mostly from hemorrhage. In other countries that have more cholera and things like that, it could be more from volume loss and dehydration, but primarily hemorrhage in the setting of trauma, which you're gonna do blood transfusions. Why in hypovolemic shock are vasopressors not really a good solution? What do vasopressors do? Right? Vasopressors would increase afterload, but your body's already compensating by increasing the afterload. So giving vasopressors doesn't really help this condition that much because the compensatory mechanism going on here is increasing afterload. If we go up to distributive shock, we said, let's give vasopressors here, right? Because in distributive shock, you get vasodilation, you get a low afterload. So giving vasopressors will increase that afterload. Whereas in hypovolemic shock, your body is already increasing the afterload, right? You don't have vasodilation here. This is simply you don't have enough fluid, whether it's because you're bleeding or because you're dehydrated. You don't have enough preload. So you need to address that with fluids if it's dehydration or packed red blood cells. The packed red blood cells will improve the arterial oxygen content. The fluids will improve the cardiac output, right? And these things together will increase the amount of oxygen delivery that hopefully can then keep pace with oxygen consumption. All right, that was shock state number 2. Shock state number 3, cardiogenic shock. So cardiogenic shock is essentially the pump. The heart won't squeeze well enough. And this can be from a lot of different things, right? Maybe you had a heart attack or a myocardial infarction. Maybe you have severe valve disease. You have a really bad valvulopathy. Maybe you have, really bad I already said infarct. So anything that causes myocardial damage, maybe you have really bad, myocarditis, right? Or inflammation of the myocardium. Anything that causes that heart to not be able to pump effectively. So what is happening then, right? We have myocardial injury or dysfunction, and the pathophys in this equation, right? Heart rate, preload, contractility, afterload. Think about what is going to be affected here, right? Because oxygen delivery to go into shock is not enough to keep up with oxygen consumption. And then we know oxygen delivery is proportional to these things. Heart rate These are all stroke volume together. So heart rate and stroke volume are cardiac output. And then this together, hemoglobin, oxygen saturation, and dissolved oxygen is going to be the arterial oxygen content. So what is deranged in cardiogenic shock? Give you a hint. I said it. Decreased contractility. The pump cannot squeeze well enough. So what your body does to try to compensate here is it increases the heart rate and it increases the afterload because it thinks that by increasing the afterload, you might be able to increase stroke volume and improve cardiac output. The challenge here is the body actually does somewhat of the wrong thing in cardiogenic shock, or it can turn into the wrong thing. Because if the heart is not able to squeeze as well, sometimes its compensatory increase in afterload leads to worse cardiac output because this pump that can't pump that well is trying to push against higher afterload. So this is one of the few times when our interventions sometimes are going to contradict the body's compensatory changes. All right, so what do we do in cardiogenic shock then? What do we intervene on? Well, the easy answer here is if contractility is worse, we increase contractility, right? We use inotropes like dobutamine or milrinone. You can use mechanical circulatory support, Impellas, balloon pumps, ECMO, all these things to help, contractility or take the place of contractility. All right. With the contractility suffering, sometimes we see an increase in preload as well, an increase in afterload. And as we said, these things can, even though the body's doing it to compensate, it sometimes can hurt the cardiac output. It can fall off the curve. So sometimes in these patients, we actually are going to say, we don't want you to compensate. We're going to decrease the afterload. We're going to give an arterial dilator, right? So afterload reduction can sometimes be a treatment. Things like nicardipine, I guess it depends on where you work, but nitroglycerin, nicardipine, clavitipine, all sorts of stuff to decrease the afterload. And then sometimes we want to decrease the preload because sometimes you get this venous congestion, right? If the heart can't pump well enough, you can't pump all the blood returning to the heart. So you sometimes want to diurese them, right? Try to get them to pee off some of this increased preload. So unlike the other shock states, cardiogenic shock, sometimes the compensation the body's doing can be bad for cardiac output, and we have to intervene to get these compensatory mechanisms offloaded by decreasing the afterload, decreasing the preload. And then the thing that makes the most sense here is augmenting the contractility, because that is what is pathologically reduced in cardiogenic shock. All right, so that was shock state number 3. Last but not least, obstructive shock. So obstructive shock is very polyfactorial. Fun word that I wrote. So the causes of obstructive shock are anything that causes obstruction to forward flow. So the big thing is a pulmonary embolism. All right, so pulmonary embolism, if we draw a heart, right atrium, left atrium, right ventricle, left ventricle. The right ventricle is going to pump blood through the pulmonary vasculature to the lungs, right? If we have a huge pulmonary embolism in this pulmonary vasculature, that right heart can't squeeze, and you go into right heart failure or obstructive shock, all right? Another one here, let me delete this, is going to be tension pneumothorax, all right? So tension, oh look, I forgot a Y, tension pneumothorax or PTX. So in tension pneumothorax, you have 2 lungs, right? And then you have a heart that sits here, and this is all encased in the thoracic cavity. Tension pneumothorax means you get a hole in the lung, which causes all this air to leak out into the thorax. This increases the pressure out here. That causes the pressure to increase so much this lung collapses, and it can squeeze on the heart so that the heart can't get enough filling of blood, right? Because all that pressure is pushing on the heart, and as such, it doesn't have enough blood to pump out. That is distinctly different than pulmonary embolism, right? This is that there's pressure squeezing on the heart, so it can't get enough preload to fill. Whereas pulmonary embolism is there's too much afterload that the heart is pumping against. So you can see here that unlike, well, more so than the other categories, there's a lot of kind of polyfactorial causes here. Another big thing is cardiac tamponade. So cardiac tamponade is the heart is encased in a pericardial sac, right? And this pericardial sac can sometimes fill. Ooh, did I freeze here? Touch off. Let's put the touch back on. The pericardial sac can sometimes fill with fluid. The pericardial sac can sometimes fill with fluid, right? And if this fluid is filling up and up, it will also compress on the heart, so it can't get enough preload to fill the heart, and thus it can't pump blood out. So when we talk about kind of the pathophysiology here and then the compensatory changes, it's all super variable. Some have increased afterload, some have decreased preload, some has decreased contractility, et cetera, et cetera. Something that you can count on is that, so we said like some of them cause decreased preload, some cause increased afterload, some cause decreased contractility. Compensatorily, you almost always get an increase in heart rate, right? Because we know heart rate, these three things are stroke volume, these make up cardiac output. So you always see an increase in heart rate. But the other modulation here, the other thing we intervene on, will depend on what's going on. If you have a huge pulmonary embolism, that's going to cause this huge increase in right ventricular afterload. So what we do is we go in and we try to get rid of that clot to decrease the right ventricular afterload. If you have a tension pneumothorax, that's going to cause a huge decrease in preload because all that pressure is not allowing venous filling of the heart. So what do? We can go and we can give a bunch of fluids and then also fix the pneumothorax, put in a chest tube so that there's not as much pressure on the heart, right? So chest tube. Same thing if it's tamponade, that's squeezing on the heart, decreasing preload. We can give fluids, or we can give, and then we drain the fluid with a pericardiocentesis. So lots of variability in obstructive shock, which again is why we're saying these four categories are good for kind of initial understanding, but they're very polyfactorial, they're very multifactorial. Not every state within each one of these general categories causes the same derangements. But those are the four general categories of shock: distributive, hypovolemic, cardiogenic, and obstructive. That is a framework for understanding them as related to oxygen delivery and oxygen consumption based on that first video we did. Again, check out the videos linked in the video description. Let us know what thoughts, comments, questions you have down below. This is a very complex topic, but hopefully that provided you all at least with a structure and framework to start understanding these as related to patient care in digestible and intervenable nuggets. So let us know what you think. Subscribe, hit the bell button, like, all that good stuff. We appreciate y'all. Stay well, keep learning. We'll see you next time.